at Sunnybrook who do the tests and who helped me a great deal with putting together the test taking tips and tricks that I tried to share with you tonight. So thank you very much for that. And I've still got about a half an hour to go through some of the questions. Hopefully we can get to most of them. So the first question came from Beth, even before the webinar actually started. And the question is, difficulty seeing in low light conditions. Is there a relationship between this and the results of a visual field test? Basically, yes. There are other diseases which give difficulty seeing in low light conditions, but they will also probably have abnormal visual fields. Many diseases cause changes on these tests. Part of my job is to try and figure out what is glaucoma and what is something else. But if you have difficulty seeing in low light conditions, then the chances are that the visual field test will be abnormal. Right, I'm going to stop screen sharing, I think, because it's better for the question and answer if I keep it up this way. Okay. So the next question comes from Fania. And it says, the eye surgeon suggests immediate surgery for my glaucoma, while my ophthalmologist suggested there's no urgency. Whom should I trust? Well, an eye surgeon is an ophthalmologist. I'm wondering if the other professional is an optometrist who is not a surgeon. I can't tell you, hopefully they both have your best interests at heart, and you'll have to sit down with a surgeon and ask them to be more clear about why they think it's urgent. But that's a question specific to you, and I can't answer more than that. Next question is from Diane, and saying, is there a correlation between OCT, visual field, and intraocular pressure changes? Good question. Lengthy answer. OCTs and visual fields are correlated. Generally speaking, and there's exceptions to every rule, we sort of feel that most people will see changes in the OCT first, while the visual field remains fairly good. And later on, the OCT may be completely uninformative, and the visual field is more what we rely on. The intraocular pressure is what we treat. It's what we look at. It's the #1 risk factor for developing glaucoma. But you can have bad visual fields and normal or even low intraocular pressures. And you can have high intraocular pressures and have absolutely normal OCTs and visual fields. So the intraocular pressure is less correlated to the test results. Having said that, if your pressure is too high for too long, you will get OCT and field changes. So it's not like the IOP, the intraocular pressure, is not important, but at any particular level within the normal range or a little above can be normal or abnormal depending on the person. Next question from Vicky. You're welcome, thanking us for the webinar. The question is, can glaucoma give someone photophobia? Generally, no. Photophobia comes from a number of other things, including inflammation in the eye, cataract, something that breaks the light up, but mostly glaucoma is asymptomatic, people don't notice anything very much, or they notice difficulties with light and dark adaptation, slow adjustment to dark conditions, but typically photophobia, meaning being dazzled by bright lights, is not a symptom. Okay, next question from Angelo. Can vascular health of the eyes, for retina and optic nerve, also contribute towards cause of glaucoma? If so, are there ways one can diagnose vascular health of the eye? There's been an enormous amount of research over the last 25 years or probably more, looking at the vascular health, so the flow of blood into and out of the eye. So far, there hasn't been a test which has been sufficiently sensitive and specific enough to be used for glaucoma diagnosis in the range of the blood flow at the back of the eye. There's a strong sort of belief in the glaucoma field that those with glaucoma at normal pressures may have some disturbance to the optic nerve, but it's not something we measure, not something that we at the moment give a specific treatment to. If you have a complete disturbance of the vascular flow into the eye, the central retinal vein blocks off, or you have diabetic retinopathy, that can predispose towards a specific subtype of glaucoma. But that's a little bit perhaps too nitty-gritty for a talk like this. Okay, there's another question from someone asking about their own situation, and I'm afraid I am going to skip over this. Next question from Myrna says, what is on the horizon for new tests, new equipment, and or artificial intelligence to trend more data and new predictive models? There's a research meeting called the Association for Research in Vision and Ophthalmology, which has been virtual for the last 2 years, sadly, where one goes to see what's just edging over the horizon. There's quite a lot of interest in artificial intelligence, deep learning, in eye disease in general, trying to get the visual fields and the OCTs to leverage some of that technology to get better diagnosis, especially for remote care, so that people in the far north can be diagnosed without having to trek all the way down to Toronto. All very exciting. I don't know whether I will be using that kind of technology in my practice in the next 5 to 10 years. I wouldn't be surprised if I didn't. I'd be very pleased if I could. Okay, just having to chug up and down. Another quick question about webinars on the treatment options with high pressures. We might do that. Put it in as your request when you get the survey. Okay, question from Rafe. Thank you for the webinar. On the OCT printout, the vertical cup to disc ratio is listed separately. Does the vertical cup to disc ratio matter more? Yes, it's felt that glaucoma damage to the optic nerve is a little bit more early at the top and bottom of the optic nerve, so that changes occur in the vertical direction more than the horizontal direction. So we tend to look at that with a little more attention. Okay, from Dominic, which is a better test, visual field or OCT, to indicate or predict accurately the optic nerve health? I tried to suggest that the two tests do complementary things. One is looking at the function, which is the field, one at the structure, and at different stages of the disease, one test might be a little bit more favored over the other. I would hate to have to use only one. I really want both because they're complementary. Okay. Another question about a personal point. I'm going to skip. Question from George. Are there patients in which damage to the optic nerve is reversed? And there was another part to it. And there we go. And what could help with that? There are occasionally reports of people where you do a very high pressure, you lower it well with surgery, and some of the damage appears to reverse, perhaps because the nerve tissue was compromised and suffering, but hadn't actually died off. Once the nerve tissue is dead, you've lost the nerves, we cannot currently make them grow back. And there's equally a lot of research looking into protecting the optic nerve against pressure and getting it to regrow, not currently possible. Okay, so question here from Shirley about, due to severe short-sightedness, the ophthalmologist said that the OCT would not be meaningful. Are there other tests besides visual fields? So yes, if your baseline tests are outside the normal range, then the test will only indicate that you're outside the normal range, and it might be from any one of a number of reasons, like being highly short-sighted or having other diseases in the eye. Sometimes you can still get information about change. So the test may not be completely worth nothing. And sometimes we have to go on to looking at other tests like the visual field. In some people, the tests aren't helpful at all. We just have to do our very best with by keeping the pressure down. Question from Anonymous about, is it safe to wear contact lenses if one has glaucoma? Generally, yes. It can make taking drops a little bit more complicated, but it's not usually a major problem. Okay, question from Marilyn saying, I can no longer do a visual field test due to hand issues. Are there other tests being researched to deal with people with hand disabilities? I'm not sure of all the variations in visual fields that are being studied. There are some that are looking at virtual reality headsets and so on. They may be measuring in ways other than requiring a clicker, but I don't have a specific answer. Okay. So another question from Anonymous asking about the GCC measurements in the OCT. What is the significance of FLV being normal and GLV being abnormal? I'd have to look at the test results, I think, to be able to give you an answer to that one. Question from Dominic saying, I rest my chin on the chin rest, but my eye is not at the same level as the center target. Does it matter? Broadly, the more centered you are, the better. The technician should be able to adjust things reasonably well to get you centered, but small deviation is probably not that much of an issue as long as you look steady and answer accurately around. Questions I fear are coming in a little faster than I can answer them. Question from Patricia, are there best types of glasses for those with glaucoma, bifocals, progressives, etc.? Short answer, whatever works for you. There's nothing specifically good or bad for the glaucoma. Okay. Question from someone anonymous, many provincial health insurance only cover eye exams once every 2 years. Yes, in Ontario, and that's the only one I can speak to, medical disease, whether it's glaucoma, diabetes, macular degeneration, are covered, and you can have as many exams as you need. Question from Ralph, after trabeculectomy, which is surgery, what can be done to bring pressure down from 13 to preferably 10 other than drops? Well, probably drops. Sometimes the surgery can be worked on, but getting from 13 to 10 is not an easy thing to do. We seem to be getting out of the visual field questions here. Okay. Anonymous question again. Does the elevation of your head while you sleep affect your glaucoma? Does it cause a headache upon waking up? No idea about the headache. Generally, it's felt that when you lie flat, your eye pressure actually goes up a little. And if you sleep with a slight elevation, you may actually be doing better for your eye pressure overnight. There's some research that's been done in Toronto by some of my colleagues, but it requires a sleep lab and is difficult work to do. Okay. Question from Peter saying, my visual field graph is decreasing over time. I now have limited vision. Will the decreasing trend ever become, I'm not sure if it's asymptotic or asymptomatic. I'm assuming from context that he's asking whether the trend will slow down so that the limited vision will remain. Hopefully, yes, not necessarily. As I said at the beginning, glaucoma is a blinding disease, and sometimes, despite our best efforts, the visual field loss just keeps going until there's nothing left. We do our very best to avoid that, and I don't know, I'm not going to say what your own personal prognosis is going to be, but sometimes we can't slow it down despite our best efforts. Anonymous again, I'm hoping this is multiple different anonymous people asking about whether there's an ongoing study looking into a reversal of blindness. Again, that would require the ability to regenerate the optic nerve, grow neurons from the eye back into the brain and have them hook up to the next step in the visual cascade in the brain. Might happen. I don't see it imminent. Question from Cindy asking, what do you tell your patients who ask about the use of marijuana to treat glaucoma? It's a good question. We don't get asked as often as we used to now that the glaucoma is, that marijuana is more available, but I don't recommend it. The Canadian Glaucoma Society doesn't recommend it. The American Ophthalmological Society doesn't recommend it. Marijuana does lower the eye pressure for 2 or 3 hours while you're stoned. But glaucoma control requires steady 24-hour pressure control as smooth as possible. You're not going to get that by smoking once a day for 3 hours. And if you're going to smoke every 3 hours to keep your pressure down and be stoned all day, that's not a good treatment for your glaucoma either. There's also the concern that it affects the blood flow to the back of the eye, to the optic nerve, and may actually be counterproductive at the same time as it's lowering the pressure. There's some interesting research looking at parts of marijuana, some of the active molecules, to lower pressure rather than without having the mental side effects, but very premature. There's also some evidence that the CBD oil, which does not make you stoned, might actually have the counterproductive effect of raising the eye pressure. So I generally tell people to stay away from stay away from marijuana, especially if the disease is bad. Okay, question from Kerry. There seems to be more people who have normal pressure glaucoma. Has the incidence increased, or is it just that screening is picking it up earlier? Good question. Either of those, I would think probably there's just more screening. 20 years ago, maybe a little more now, it was generally felt that you didn't have glaucoma unless your pressure was over 21, and then you did have glaucoma. It was just kind of a hard line. Now we know quite well that's not true. So people are more on the alert to look for other signs of glaucoma than just the pressure, so that we pick it up as early as possible. Next question from Anonymous. Does a high level of myopia predispose the patient to glaucoma? Myopia, or being short-sighted, is generally considered one of the risk factors for developing glaucoma. Very high short-sightedness has other issues as well, but certainly people with the high myopia should be at least screened for glaucoma on a semi-regular basis. Okay, question from Debbie. Is surgery successful in stopping the progression of glaucoma? I think I just lost it. Yeah. And what are the risks? Okay, we're planning a surgical seminar later on. So I'm not gonna go through all the risks and benefits of the surgery. It can be successful in stopping the progression of the disease, but nothing is, not always, and there are risks. But if we feel that the risk of the situation untreated is greater than the risk of the surgery, then we're going to recommend surgery. Okay, Anonymous. If OCT and visual field remain stable, how would you deal with elevation of eye pressure, drops or laser? Yeah, drops or laser. If the pressure is high enough that it really requires treatment despite the field and the OCT remaining stable. If the disease is stable, probably allow the pressure to run a little higher without worrying about it. And if the disease is progressive, then the opposite is true. Okay, from Brenda, do you recommend laser iridotomy in patients with higher than normal pressure but normal visual fields? Only if they have the narrow angle configuration that reaches the criterion at which we recommend laser iridotomy. That is for acute angle closure and not the open angle glaucoma that we're really talking about long-term testing for. From Patricia, is there a standard by which you decide the loss of peripheral vision means no longer driving? Yes, the standard is set by the Ministry of Transport of Ontario, and it requires that the visual field have no defects within the central 120 degrees laterally and 15 degrees above and below, at the level that the ministry has decided to test at. So you can have an abnormal glaucoma visual field, but still have a legal driving field. However, very often, if the glaucoma field is bad enough, the driver's field will be affected, and then that mandates the ophthalmologist to let the ministry know, and the Ministry of Transport will pull the driver's license. This is always a very difficult conversation to have with the patient because their vision is usually good, and they're often very unaware of their glaucoma. It doesn't affect their day-to-day living, and yet they are going to lose their driver's license. That is because the standard for the visual field is set, as it should be, fairly tight to maximize the safety of everyone else on the roads. Question from Sharon, can eye drop medication control glaucoma indefinitely, or will surgery be needed at some point? Some people stay on medications their life and have no problems. Other people go on to surgery. So the answer to that, I'm afraid, is it depends. Question from Carrie, how often should these tests be done? Once or twice a year is pretty standard. If the situation is unstable and the tests are getting worse, then they'll be done more often. If the situation is very stable and the glaucoma is very mild or a suspect, then perhaps just once a year. So like an awful lot in this field, it depends. Question from Peter, are there some exercise-like activities like 8 hours of sleep with eyes closed, eye exercises, etc.? No, there's no exercise that's going to have any impact on your eye's ability to manage its pressure or to improve the health of the nerve at the back. So no worries about exercise. Okay, that one we did. Question from Philip, is there a connection between cataracts and glaucoma? Not really. They're both more common with increasing age. So you tend to find them coexisting in older people. Increasing cataract can lead to an angle closure situation. So the acute angle closure glaucoma that I mentioned briefly before. And there's a couple of very sort of unusual glaucomas that can be caused by a lens that's too big or getting too mature, but those are very rare. Follow-on question, would removing a cataract lower pressure? Usually a little bit, 1-2 points perhaps. It probably just taking the cataract out allows the drains to kind of open up a little bit more. It's not usually enough for a significant glaucoma treatment, but it's a nice little bonus when you do the cataract. Okay, there's a question from Dominic about double images after watching television. Probably when your eyes are closed, the muscles just drift out a little bit. When you open the eyes up again, the images snap back together. But I'm not an expert in double vision, and if it is a problem, you need to see someone who is. Question from Anonymous, are there less invasive surgeries than trabeculectomy? Yes, there's a whole series of new variations on surgery called minimally invasive or micro-incisional glaucoma surgeries. They are a little less invasive, they're a little safer, and they're also a little less effective. So they're not the best fit for everyone, but they are options. Question from Annie, how much time in average before someone will become blind? Well, it depends on how bad the glaucoma is when we start the clock. If you take it from someone who's normal and then develops the very earliest glaucoma and they're not treated, because hopefully treatment will prevent them from going blind, loss of vision to a level of legal blindness might be 15 to 20 years. But if it's a very aggressive form of glaucoma, it might be less than 5. So it's not something that you can say, oh, I've got 15 years, I don't have to treat it and leave it. I will treat someone in their 90s because I don't want them having an aggressive form of glaucoma that's going to blind them when they're 95 and they spend the last 2 years in the dark. Okay, question from Anonymous, basically about the difference between brand name and generic names. On the whole, the generics work pretty much as well as the brand names. Sometimes they're not quite as comfortable because the preservatives are different. I will generally go with the generic unless there's a specific reason for choosing a brand. Question from Brenda about, has there been any correlations between eye drops and any other negative long-term health impacts such as cancer? What a horrible thought. To the best of my knowledge, no. You can get some systemic side effects from some eye drops, but generally stopping the eye drop solves the problem. Question from Carolyn, any studies on the effect of diet on glaucoma? Lots of studies, or at least some, nothing very useful. A good healthy diet, lots of green leafy vegetables, that sort of thing. Nothing that's really going to specifically improve glaucoma control. And there's another question from Anonymous about lifestyle changes, essentially asking the same thing. And the answer is much the same. Broadly speaking, aerobic exercise, a good healthy life is good, smoking is bad. The only thing that occasionally we'll mention, if you have bad glaucoma, it's advanced, it's progressive, it's getting worse, then, okay, and this is actually the last question that I'm going to answer, just popped up. Avoid head down exercises, so downward dog in yoga, headstands, spine stretching. Avoid heavy resistance training, so massive weight training. Those have been shown to increase the eye pressure. And if your disease is getting worse despite what looks like good control and you're taking your drops and you've had your surgery, those might be things to think about, whether they're impacting your day-to-day activities. But in someone whose glaucoma is well controlled, stable, there's very little need to affect your lifestyle particularly. So I think that's a good point to end on. I'm impressed at the range and insight of some of the questions that we've gone through tonight. And just on 8 o'clock, thank you all very much for attending, and keep your eyes out for further invitations to more webinars and our annual supporters meeting in the fall.
Thank you so much, Dr. Birt. That was wonderful and very informative. Thank you so much, everybody, for joining us, and take care. I'll end the meeting here. I will send out a link to everybody who's registered and the survey as well. But thank you for joining. Thanks again to Allergan and AbbVie Company for sponsoring this evening. And if you have any questions or comments, please feel free to get in touch with me. My email address is info@glaucomaresearch.ca. Thanks, take care, and have a great evening, everyone.
Good night.